Les voy a presentar un caso al panel para que sepan, y como el caso lo van a ver fácilmente, lo voy a decir en inglés para que el doctor Ma y el doctor Tom puedan participar. Next slide, or here, let me pull it up from here. Great. So this is a case that was presented at Grand Rounds by one of our fellows, Dr. Neda Nickport, and several of us participated in the care of this case. So I'm going to ask Dr. Amezcua not to participate in the discussion. I think Dr. Tonk certainly knows this case very well. So this is a typical case that we see in Miami at any time, and the history is a 22-year-old contact lens wearer that had a history of poor contact lens hygiene, and this ulcer had been present for approximately 3 weeks and had been treated prior to reaching us with moxifloxacin, steroids, PHMB, chlorhexidine, and acyclovir, thinking that perhaps this was an Acanthamoeba, a viral, bacterial, and maybe a fungal keratitis. There were a couple of other interesting things about this case, and this is a student at the University of Miami. He's on the tennis team on a scholarship, and the person who's bringing him in happens to be his father, who's an ophthalmologist and a cornea specialist. So there are many people trying to figure out how to treat this case. So what should we do? What would be the next step? How many of you think that we should continue the current treatment? How many should start fortified antibiotics in addition to what he's on right now, which was commercially available? Start antifungals because this could be fungi. Stop everything? Sorry? It was culture. Yeah. So stop everything. Do a penetrating keratoplasty. Tell the father to leave the room so we can make a decision. Okay. So at that point, Dr. Amezcua decided, let's phone one of you guys to see who can help out. So Dr. Amezcua and I and Darlene Miller were asked to participate in the case, and Dr. Amezcua put together this very nice paper some years ago on how to manage in a strategic way unresponsive corneal ulceration. And here we see that when we have a case like this, we certainly want to do scraping, confocal microscopy, possibly a biopsy, and start fortified antibiotics. If it's a severely thinning case, then you may need to go to a therapeutic tectonic penetrating keratoplasty, or as Dr. Juan Valle, very intelligent, said, let's stop everything and let's repeat the cultures to see what's growing there. So certainly if we identify an organism, we have a happy face and everything is great because now we know what to treat, but oftentimes we have a crying patient because we don't identify an organism, and then we have to decide, because this is a progressive infection, what to do next. And one of the things that we can do next is either look for additional treatments, in this case PDT, or to challenge and see if we can make an organism come out by using topical corticosteroids in a very controlled way as a challenge to see if something does grow. So cultures were taken, fortified antibiotics were started, and we watched the patient closely, but the patient continued to worsen. Again, we were challenged with trying to decide what would be the next step, continue the current treatment, start empiric antifungals, corneal biopsies, stop everything and biopsy, or do a therapeutic penetrating keratoplasty. Any thoughts from the panel? Dr. Gibbons, what would you do?
I have a very low threshold for biopsy at this point in my life.
Biopsy?
Yeah.
Dr. Ma?
I would agree with the choices. I would definitely, stop everything and then biopsy, especially since you don't have anything.
Okay, Dr. Otero?
Yeah, me too. Corneal biopsy. I think that would be
Okay. So we went ahead and stopped everything, followed the advice of the experts on the panel, and did a corneal biopsy with copper 4 white, microbacterial smears and stains, and also looked for herpes by PCR. Because of the lack of response, we decided to go ahead and add natamycin and oral antifungals in this young man that we were trying to see what we would treat. So this is how he looked a week later, and there seemed to be some sort of slow progression, but hard to tell compared to what he looked like before. And still no news. So all we had was the clinical appearance with everything that we had done negative. And just to remind you, so now he was on treatment for about everything. We had actually stopped the antibiotics because we felt that he had already been treated with antibiotics long enough, fortified antibiotics, and that there may be some level of toxicity going on. So now, so we've done the biopsy. After stopping everything, what would we do next?
Now the biopsy needs to be done by the chairman.
So what do you think? Dr. Gibbons?
Well, we could try something that might have a broad spectrum of treatment amongst different things. I know Dr. Mess was experimenting with prostaglandin lately.
All right.
That might kill everything and or stabilize the rest of the stroma so it can withstand any further thinning.
Good. Anything, Dr. Mar, Dr. Otero, that you would do?
send it back to his father.
Send them back to his father. So the panel says, let's ask the really people who know how to do things, the audience, anything that you would do different. ¿Alguien haría algo diferente? No, 22-year-old, very healthy. The question over there was he a healthy guy? Very healthy, 22-year-old tennis player from the University of Miami.
He wasn't using steroids, topical anesthetics, right?
No use of topical anesthetics.
Su papá era como un perro policía que lo tenía aquí todo el día.
All right, so we decided to go and get a bigger piece of tissue. So we did, in this case, what we do in some of these cases, a deep lamellar biopsy by elevating a piece of the anterior cornea in the operating room and aspirating the anterior chamber and taking a big chunk of posterior stroma that we could culture. And we put intracameral voriconazole and also subconjunctival as well as intracorneal. So 1 week after the biopsy, this is how he looked. He felt fine. He wasn't feeling a lot worse. Very stoic young man. This was his current meds, to remind you. And this is the biopsy. So what organisms do you all see here?
Piece of cornea.
We need a real pathologist. Yeah, oh, yes, of course. When a pathologist says that they don't know what it is, they say, make it bigger so I can tell what it is.
High power field, low power mind.
Huh?
High power field, low power mind. That's what the pathologist says.
Okay. So the biopsy result didn't show any organisms. Special stains were done, and there was nothing in the biopsy to clinch a diagnosis. So now we have him on all these medications, and he's not doing any better. We're talking to the father about penetrating keratoplasty, but the father, who's a cornea specialist, says, I don't want my 22-year-old son to have a penetrating keratoplasty. He's a tennis player, and he needs to go back to the University of Miami. He's going to miss his semester, and I don't think it's a good idea for him to have a penetrating keratoplasty. So he continued to worsen, so we had done all these things, and so the next step was to go to our expert, Dr. Jean-Marie Perel, in the ophthalmic biophysics laboratory and attempt this novel treatment of rose bengal PDT. And so that was done, and maybe Dr. Amezcua can narrate a little bit of how we do the PDT treatments, as you've done it so many times.
Bueno, el paciente se recuesta en la sala de examen con anestesia tópica o subconjuntival, dependiendo de cómo esté el dolor. Se aplica rosa bengala 0.1 y se aplica por media hora, una gota cada 3 minutos hasta que se sature la córnea. Para esto se debe quitar lo más que podamos de epitelio. Y aquí el epitelio, gracias a nuestro estudiante de medicina que estaba en el cuarto, dijo, pues ¿por qué no lo mandamos al laboratorio? Pues ya lo quitamos, ¿no? Y lo mandamos. Entonces...
Wait a second, don't let the cat out of the bag yet.
Yeah, lo mandamos. Entonces, siempre que hacemos eso, quitamos el epitelio, mandamos al laboratorio y se hace la luz por 15 minutos.
Great, so así es como lucía el paciente. A day after the PDT, 5 days after the PDT, he's seemed better to us. The father also felt that he was doing better, so we were all very encouraged. So that was 1 day prior to the PDT and 5 days, and you can see there is some improvement. He was continued on the topical treatment, and then the PDT was repeated 9 days later, and then we did get a culture result. So what was the medical treatment and the PDT treating that this patient was getting better? What? Darío says atypical mycobacteria.
That's a good.
Sounds good to me.
Yeah.
So, the big surprise was that the culture was growing Acanthamoeba. So it's, as we heard before by Dr. Otero, it's a tough organism to grow. And so this is just to show you how he looked. And he continued to improve. Dr. Amezcua recently did a penetrating keratoplasty, and he's now on the U.S. Davis Cup team, playing for the United States because he's seeing so well with his eye. And Dr. Amezcua, congratulations on a good care of this patient.